Sleep disorders. Letter of referral. Dear Dr. Mr. Frank Richards, aged 60 years. Thank you for seeing this self-employed businessman with excessive daytime sleepiness, which is now interfering with his work and social life. Most recently he fell asleep whilst driving and is understandably concerned. He has a past history of ischemic heart disease, with a myocardial infarction 5 years ago followed by coronary artery grafting. He is now free of cardiac symptoms. His regular medications consist of bisoprolol, enalapril, atorvastatin, and aspirin. He is obese, weight 113 kilograms, BMI 35.7. Yours sincerely. Introduction. This patient complains of daytime sleepiness is not an infrequent referral, but the narcoleptic syndrome is much less common, and even if patients tell you that they have narcolepsy, other causes should be considered. Differential diagnosis of excessive daytime sleepiness. Insomnia, insufficient sleep. Non-restorative sleep. Narcolepsy. History of the presenting problem. A sleep history is required. What time does the patient go to bed? When does he wake up in the morning? How often does he wake during the night, and what does he do when he wakes? Exactly what does excessive daytime sleepiness mean? How often does he actually fall asleep, and has he ever fallen asleep when trying to stay awake, e.g. when driving, as in this case? The answers to these questions will help to place the problem into one of two categories. 1. Insomnia. Table 8 lists the most common causes for an inability to obtain sufficient sleep. Further questioning should be designed to address these issues. 2. Non-restorative sleep. The patient appears to spend a sufficient time asleep but does not awake refreshed. The main causes of this are shown in Table 9. Could the patient have any of the conditions listed in Tables 8 and 9, or narcolepsy? Further history should be directed to looking for evidence of the following conditions in particular. Obstructive sleep apnea. Does the patient have a morning headache? Patients with obstructive sleep apnea retain carbon dioxide, resulting in headache. The observations of a partner are essential. These will not be directly available in PACES but may be recorded in the referral letter. The important issues include the following. Does he snore loudly? Does he sometimes appear to stop breathing? Does he resume breathing with a large gasp? Central sleep apnea. There will usually be a history of a brainstem event or of other symptoms to suggest more widespread neurodegenerative disease. Parasomnias. NB. Parasomnias are rare in an adult population and can only be diagnosed by a witness account. These are a group of disorders that usually start in childhood and can be linked to particular stages of sleep. They can be disorders of movement, including hypnic jerks, periodic movements of sleep, sleep paralysis, and sleepwalking, disorders of autonomic function with symptoms of sympathetic overdrive, or more complex abnormalities such as sleep terrors. Narcoleptic syndrome. This is classically defined as the triad of narcolepsy, cataplexy, and hypnagogic hallucinations, and other parasomnias, especially sleep paralysis, although not all patients will have all the symptoms. Narcolepsy. Daytime sleep attacks often occur without warning, at times of emotion and after a carbohydrate load. Typically patients feel refreshed after each episode of sleep. Cataplexy. These are episodes of partial, often face or jaw, or complete loss of muscle tone that result in the patient falling to the ground. They are often triggered by strong emotional stimuli, usually laughter. Hypnagogic hallucinations. Pre-sleep dreams associated with sleep onset rapid eye movement, REM, activity. In sleep paralysis, which is not restricted to the narcoleptic syndrome, the patient feels completely paralyzed at sleep onset, less commonly on waking, and this feeling is often associated with terror, anxiety, and fear. Recovery is spontaneous. Other relevant history. This is important in the case of central sleep apnea. Adults with parasomnias may have been sleepwalkers or tooth grinders as children. The family history may be relevant in some rare diseases. Familial fatal insomnia is a hereditary disease caused by an ASP to ASN mutation at codon 178 of the human prion protein gene in the presence of a methionine at codon 129. The same mutation at codon 178 but with a valine at codon 129 results in familial Creutzfeldt-Jakob disease. Fatal familial insomnia is a rapidly fatal disease characterized by insomnia and dysautonomia, and also more widespread neurological involvement including pyramidal, cerebellar, and cognitive signs. Plan for investigation and management. The approach to investigations and management will be determined by findings in the history. It may be that nothing more than simple advice is required. Insomnia. It is often sufficient to improve sleep hygiene, whether that means sleeping with ear plugs, lining the curtains or not drinking coffee after 6 p.m. Psychiatric and physical disorders that are felt to be contributing must be addressed. Sleep apnea. Patients who might have sleep apnea should be referred to a respiratory specialist with an interest in sleep disorders for further investigation and/or treatment. The initial test will be to monitor arterial oxygen tension overnight using a pulse oximeter, looking for characteristic drops in oxygen saturations at frequent intervals. Treatment involves weight loss and non-invasive ventilatory support at night. Narcoleptic syndrome. This diagnosis should be confirmed with a multiple sleep latency test, which is performed in a specialist sleep center. During this test, 5 episodes of sleep are permitted during the day, a rapid onset of sleep and REM sleep within 15 minutes of onset in the absence of sleep deprivation are both features indicative of narcolepsy. The excessive sleepiness of narcolepsy can be treated with modafinil or dexamphetamine. The cataplexy, sleep paralysis, and hypnagogic/hypnopompic hallucinations respond to antidepressants. Venlafaxine or other selective serotonin reuptake inhibitors are the most frequently prescribed. More recently, sodium oxybate has been approved for use in narcolepsy and effective for both daytime sleepiness and cataplexy. Further discussion. The Epworth Sleepiness Scale provides a quantitative measure of the patient's general level of sleepiness. Patients rate the chance that they would fall asleep during different routine daytime situations during the previous week. Answers to the questions are rated from 0 to 3, with 0 meaning they would never fall asleep in a given situation and 3 representing a high chance. A score of 10 or more suggests the need for further evaluation. Approximately 90% of all narcoleptic patients with definite cataplexy have the human leukocyte antigen, HLA, allele DQB10602, compared with approximately 25% of the general population. The sensitivity of testing for DQB10602 is decreased to 70% if cataplexy is absent. There is some evidence that hypocretin levels in the cerebrospinal fluid are reduced in patients with narcolepsy, which is consistent with a loss of hypocretin-containing neurons in the hypothalamus. An autoimmune mechanism may be responsible for this loss.